Hello. Okay. Good morning, everyone, and welcome to the second day of AP-IAP 2025. My name is Suvasan Sipodok, and it is my honor to be your moderator for this morning session. So we're gonna start a bit early because we have a special session just apart from our schedule. So you are now in room A of the 14th Asian Pacific International Academy of Pathology Congress, AP-IAP 2025. And this year we are very lucky that we have many association and academies that joined us this year. And for today, we are going to have a company meeting from the 7th Asian Society of Dermatopathology annual meeting with us today. And without further ado, I would like to invite Professor Suot Tan, the President of Asian Society of Dermatopathology, and Dr. Pranita Sithinamsuwan, a representative from IAP-Thailand division, to address the opening speech. Please welcome.
Good morning, everyone. Very good to see you. So I'm Dr. Tan from Singapore, the current president of the Asian Society of Dermatopathology. And this is, in fact, the 7th edition of the annual meeting of the ASD, which is held in collaboration with the 14th Asia Pacific International Academy of Pathology Congress here in Bangkok. So I just want to thank Dr. Pranita Sithinamsuwan and Dr. Supasan Sripodok from the local organizing committee for making it possible for ASD to host its annual meeting with the academic excellence of the IAP Congress while enjoying the warm hospitality in Thailand that you are known for. I would also like to thank Dr. Nopadon Nopakun and Dr. Punawi Suti Kunaseth for the help in facilitating this collaborative effort, leading to the fruition of this annual meeting of the ASD. So the organizing committee, together with ASD, has done a wonderful job of curating a scientific program over the next 2 days with a cast of experts from the US, UK, Australia, and Asia. And we have esteemed experts, Professors Victor Prieto, Alexander Nirenberg, Eduardo Colangre, Thuy Phang, Alejandro Gru, and Jacqueline Jenkins-Hopkins, and of course, many other experts from East Asia, South Asia, and Southeast Asia. And we will have keynote lectures and symposia covering the themes of melanocytic lesions, inflammatory dermatosis, vascular and soft tissue tumors, and cutaneous lymphomas. A DermPath meeting will not be complete without case presentations. And in addition, Dr. Nopadon Napakun has put together a local showcase of challenging cases at the end of each day's program. So I would say it is almost like having a full-course dinner, ending with great local dessert every day. So much as you'll be tempted to step out of the conference venue into the shopping mall next door, I would advise that your time is better spent here at a meeting and you will be greatly rewarded. So I am sure we will have a lot to learn during this 2-day meeting, and may I wish you a very fruitful learning experience. And now may I have the pleasure of inviting Dr. Pranita to say a few words as well. Thank you.
Good morning, everyone. On behalf of IAP Thailand division, it is an honor to welcome all of you to AP-IAP Congress and ASD meeting, and welcome everyone to Bangkok. My name is Dr. Pranita Sithinamsuwan, a dermatopathologist from Sirirat Hospital, Mahidol University, and I am one of scientific committee of IAP Thailand division. And this year is our pleasure to host AP-IAP meeting and join with ASD meeting, which enhance the dermatopathology session in 2 days. I would like to extend my warm welcome to our speaker, including local speakers, regional speakers, and many of whom have traveled far to be with us today. And you can see that this year we have many topics in dermatopathology and also interesting cases. I hope all participants will gain a lot of knowledge in dermatopathology and use the knowledge to help the patient in your countries. I would like to thank Professor Wu and Professor Tan to help us about the scientific program, and thanks to Dr. Supasan, who is everything in this conference, and thank Dr. Nopakun and Thai dermatopathology colleagues for preparing the preview interesting Thai dermatopathology showcase. And lastly, I apologize for any inconvenient cause in this meeting if it happened. Thank you.
And next, I would like to invite Dr. Yu Hong Wu from Taiwan and Dr. Nopakun from Thailand to be our chairperson of this first symposium of this morning session, which is melanocytic neoplasm.
Good morning. Thanks for coming and join our the first session of the ASD meeting. The first, I would like to introduce our keynote speaker. It's our great honor and the privilege to have Professor Victor Prieto to be the first keynote speaker. And we know that Professor Prieto is a professor of pathology and dermatology in MD Anderson Cancer Center. And he is previously the director of the Dermatopathology and the Surgical Pathology Fellowship and chair of the Department of Pathology from 2014 to 2024. And he has been the president of International Society of Dermatopathology. And his research interests are primarily the molecular biology of molecular melanocytic neoplasm, so as well as the immunohistochemical analysis. So today he's going to introduce the latest WHO classification of melanocytic lesions. Let's welcome Professor Prieto.
Thank you to both chairpersons. Thank you to the organizing committee, to the AP-IAP for inviting me, and especially to Dr. Tan Suat Hun as the president of the society, and Dr. Panita Sitinan Suwan who have invited me. And if you allow me, in my terrible Thai, Kwap Kun Mak Krap. So as you saw, I was asked to talk about the highlights of the new classification of the WHO. But first, I wanted to recommend you, if you haven't done it, just to visit the city, because you have these fantastic treasures that are worth seeing. As everything, we'll start with an introduction. And the highlights of the 5th edition, that if you want to know, and you want to leave afterwards, this is the most important thing, because the classification includes something that I was already introduced in the 4th edition, that is the concept of pathways, meaning that to reach to melanoma, there are several pathways. So unlike what we were told years ago, in which all melanomas were the same, it's clear now that there are several ways of getting to melanoma. And also, as any classification, there has to be a clinical significance, otherwise it would be useless. So if we go back to the 1970s, the original classification that is still used about superficial spreading, lentigo-maligna, acro-lentiginous, and nodular melanoma, it was proposed almost simultaneously by two groups of people. It was Dr. McGovern and Dr. Clark. And again, if you are old like me, you know that there were several prominent dermatopathologists who didn't think that such classification was important because melanomas were all the same. But if you fast forward to the 2000s, with the use of genetic molecular studies, it was clearly confirmed that those morphologic changes were based on genetic changes. Therefore, if we have a melanoma that arises on a solar damaged skin, as this patient on the cheek, the morphology of that melanoma is different from a melanoma that arises in an area that is only sometimes exposed to the solar damage. That would be superficial spreading melanoma, because one is characterized by nest and pagetoid upward migration, and the other one is characterized by atrophic epidermis and growth, lentiginous growth along the epidermis. And those are different from the acral lentiginous melanomas that you see particularly in Asian countries, because they are characterized by not so much of a nesting pattern of growth in the epidermis, but prominent pagetoid upward migration. Or any of the three can be associated with a nodular, meaning that we have predominantly invasion of the dermis with very limited growth in the epidermis. Just as an introduction, these are the editors of the current classification. And again, if we summarize what the classification has, there is a prominent inclusion of molecular data, the proposal of the pathways that we're going to discuss in a moment, and something that I think that is also very important, the consideration and the proposal that there is a spectrum of lesions that go from completely benign to fully malignant. And again, that was something that for many years it was considered that it couldn't be. There was either a nevus or a melanoma, or I don't know what it was. So let's start with the nevi. And the molecular analysis has shown us that there are oncogenic alterations in nevi. By far the most common one is BRAF mutations, particularly V600E. And the majority of nevi, standard nevi, whether they are junctional, compound, or intradermal, they will have these BRAF V600E. Now, pigmented epithelial melanocytoma and BAP1 deficient lesions also have the same mutation. Congenital nevi are typically associated with NRAS mutations, Spitz nevi with HRAS mutations, and the heavily pigmented lesions, uveal, blue, and leptomeningeal, are associated with G-alpha-Q. So those are the GNA and GNAQ. The other thing that is very important to know, as we knew already because of the clinical experience, is that ultraviolet light is the most important mutagen in most of the melanomas that arise on sun-exposed skin. So these are the 10 pathways that are proposed, and 3 of them are associated with solar damage. From the low solar damage, which is the most common one, of superficial spreading, low CSD, as included in the classification, to the high CSD, which would be lentigo maligna, and the one that is associated probably with the most ultraviolet light damage, which is desmoplastic melanoma, and 7 that are not associated, at least that we know of, with ultraviolet light. The other thing that I think that is important in the classification is the coding of the idea of a spectrum of lesions that go from benign to malignant. And this has been proposed in the EMPATH by several of the editors and the main writers for the contributors for the classification, going from a low grade described as lesions with very low risk for continued proliferation and progression to invasive melanoma, to EMPATH-4, which would be moderate to increased risk for regional or distant metastasis, and with 2 intermediate ones, which would be the high grade, which is low risk of progression, but still there is some risk of progression to melanoma, and the 3, which will be the frank melanoma, but with low risk for distant metastasis, which would be a melanoma in situ and very thin melanomas. So that's also something that the WHO is including. So the pathways, I'm going to describe one by one, but the most important one regarding the number of lesions will be the traditional one, and that would include the superficial spreading lentigo maligna and desmoplastic melanoma. And it goes from the benign, which are the standard nevi and dysplastic nevi, to something that is included as a low risk, but I would say that in general, BAP1 deficient lesions behave in a benign fashion, so we could even include them into the benign, and to the high and to the melanoma. And each one of the pathways, as you notice, is defined by a different group of genetic alterations. So let's start with the traditional or the most common one. From benign lesions, which are the standard nevi, dysplastic, and BAP1 deficient lesions, to malignant, which is most melanomas, which are superficial spreading, lentigo maligna, and nodular. So as I said, most of the benign lesions have oncogenic mutations or alterations. So the majority of these nevi will have a simple MAPK mutation, which by far the most common one would be BRAF, V600E, followed by NRAS and MAP2K. So these, the MAP2K, and we'll see an example, but those would be the ones that were classified as a SPARC, meaning lesions that had both Spitz and dysplastic nevus features. And for the melanomas, not only the BRAF, obviously, because a significant number of these melanomas would have a reason in association with a nevus, but also NRAS, c-KIT, and NF1. So this would be the SPARC, or the Spitz and Clark lesion, in which we have a shoulder, because it's wedge shape, but the junctional component extends beyond the dermal component. We have fibrosis, lymphocytic infiltrate, melanophages, meaning that there's a host response, and there's focal cytologic atypia. So this would be one of the lesions that is within the traditional group, but is still with a spitzoid morphology. So let's go now to the malignant counterpart, which would be the superficial spreading melanoma or low CSD. That's 66% of melanomas on light-skinned individuals. So types 1 to 3 of Fitzpatrick. And sun exposure, ultraviolet effect, but also seen obviously in patients who have been using tanning beds or repeated sunburns. So this is a typical situation that occurs in tropical countries or in countries like Australia and New Zealand, in which light-skinned individuals have repeated ultraviolet light exposure. Morphologically, this is characterized by a nested pattern of growth with pagetotypal migration. And 30% of this will show a pre-existing nevus. That doesn't mean that the others are not associated with the nevus. It only means that by the time that we get a biopsy, we cannot see the pre-existing lesion. So not only the BRAF, but also multiple other mutations. Now, if we go to the more prominent solar damage, that would be characteristic of farmers or sailors or people with a strong exposure to the sun, like outdoor workers. So again, by definition, will be on the face and exposed areas. So not necessarily only the face, but also it can be the forearms. And again, by definition, will be light skin. This will be very unusual for heavily pigmented skins, like 4, 5, and 6 Fitzpatrick. Interestingly, compared to the other melanomas, they have a large time of growth before they become invasive and metastatic. So we will see the effects of solar damage in the skin, meaning that there's going to be a loss of the reach-to-reach pattern, and with a prominent single-cell growth in the epidermis and very limited pagetoid upward migration. In reality, pagetoid migration is seen only after the lesion has grown for a long time. And again, by definition, there will be solar elastosis as proof or a sign of the ultraviolet light exposure. And if you look at with NGS and RNA, you can find a UV signature. So those would be the typical changes. And regarding the genes that are typically altered, NF1, TP53, and then multiple others, including BRAF. The extreme for this group will be the desmoplastic melanoma. And again, face and exposed areas and lightly skinned individuals, and also with large slow growth, so much that sometimes they are, as you know, they are diagnosed as scars and with very little pigmentation. And because of that, they are difficult to detect, and it's probably one reason why these lesions, by the time they are discovered, they tend to be thick. Something that is important if you diagnose them is to use the 90% as the cutoff, because lesions that have less than 90% behave as standard melanomas. Lesions that have more than 90% of the invasive component with this, basically resembling a scar that I can get into the subcutaneous tissue and only with focal cytologic atypia, those are the ones that behave more as a locally aggressive tumor that is deeply infiltrative but with a low index of metastasis. So again, by definition, there will be a prominent UV signature. Actually, it's considered to be the tumor in the human body with the highest mutation burden. So more than 60 mutations per megabase, which is important because now it is considered the preferred treatment for these patients is to give immunotherapy before surgery. And those are the genetic alterations that can be seen. Now, as the last one of the standard group would be the BAP1 deficient lesions. Those were considered to be Spitz and nevi, but because of the presence of the BRAF V600E mutation, they are now included in the traditional pathway. They will have a biphenotypic pattern of growth in which there are small cells that have the morphology of a standard intradermal nevus and larger cells that they have prominent nuclei and visible nucleoli, and that's why they were considered to be Spitzoid. So 90% of them will have loss of BAP1 expression, and because you can use an antibody to detect it, and also they will be positive for BRAF V600E. So now let's leave the traditional pathway and let's get to the second main one, which is the Spitz. As you know, they were described back in the 40s by Dr. Sophia Spitz when she was working at Memorial in New York. And interestingly, she called them melanomas of childhood because one of them actually killed the patient. Now, upon retrospective review, that was probably a clear cell sarcoma rather than a melanoma. So morphologically, what are we going to see? Well, as you know, it's Spitz nevi. They're going to be very similar, all the cells, with large size, usually oval or spindle, and visible central single nucleolus. The most common mutation is HRAS, but now it's been shown that there are multiple kinase gene, particularly fusions, including ALK, MET, RET, ROS1, and we'll see a couple of those. Now, I know that this sounds complicated, but basically it's telling us that some of these alterations can be detected with immunohistochemistry, which saves us the time of doing NGS, next gene sequencing, or FISH. For example, ALK, ROS, and NTRK. Those can be detected now with immunohistochemistry. Some require FISH and some require NGS. And some of them you can suggest that the fusion because of their morphologic features, and some of them that you really need the special techniques. And they go through the entire spectrum from benign to aggressive, meaning recurrence or possible metastasis. But we'll see that not all of them are capable of giving metastasis, and some of them are more likely. So after HRAS, the second alteration that is most commonly seen is ALK. It's 10% of Spitz lesions, and most of them are going to be benign. So it's going to be very rarely malignant. Exophytical polypoid, fusiform to epithelioid melanocytes, and typically they have a fascicular or plexiform pattern of growth with prominent fibrosis. So this would be a typical example, wedge-shaped, symmetrical in the epidermis, with absence of epidermal involvement, and very rare proliferation. So morphologically, these cells are going to be cytologically benign. And some of the cases you can guess which the partner of the fusion is, like in this one, with prominent nucleolus, and those are typical of the NPM1 ALK fusion. But in others, you really need to do FISH or NGS to find the partner. Now, ROS, it's probably the second most common one, also in young individuals, also as most Spitz lesions. There are going to be predominance in females, and there are multiple partners. FISH is mostly normal, and they behave in a benign fashion. So far, the follow-up of these lesions is benign. Morphologically, they may have not so much pagetoid upward migration, but a transepidermal elimination of the nest, and focally mucinous, myxoid and mucinous stroma. NTRK, as you know, there are three possible proteins, NTRK 1, 2, and 3. And in general, they are going to be small cells that are cytologically benign. They have prominent gametobodies, so that would be similar to many of the Spitz. And some of them, they have rosette-like features. So those are more common in an NTRK 1. The two that we probably should remember are the BRAF fusion, not mutation, BRAF fusion and MAP3K8, because on the studies so far, these lesions tend to have more prominent cytologic atypia, and a FISH for the melanocyte can be abnormal with amplification of 6p25. So these are the lesions that are considered to have a higher risk for recurrence and metastasis. For the NTRK 3, tend to be more on the head and neck and extremities, also children and young adults. And they have also this pattern of growth of expansile involving the subcutaneous tissue. Another lesion that has been recently described as the SQSTM1 NTRK 2 fusion. Those are older individuals. Well, you have to forgive me, that 3 to 50 is actually young, so, but not as young as what we saw before. More common on the extremities than on the face, and they tend to be flat or elevated more than the nodular pattern that we've seen until now. And these are the ones that were described in the first paper with the lentiginous pattern of growth in the epidermis. Now, as I was mentioning, careful with the BRAF fusion and the MAP3K8 fusions, because those are the ones that can have higher risk of progression. Now, in the last presentation I saw from Dr. Fouchard-Derrière, he showed that in their experience, they didn't have such a higher risk. So it may have been a selection bias for the first studies. Now, you're going to ask me, why wasting the time on looking at this fusion? Well, the lesions that have BRAF or NRAS mutations are more aggressive than the lesions that I have these fusions that we've seen until now. So, and we'll see in a moment, but just remember that, because BRAF, NF1, or NRAS mutations are more likely to behave in a malignant fashion than the others. Now, the blue nevus family, or the heavily pigmented ones, in general are benign, but you can have lesions like this one with a prominent focal marketipia, 2 mitotic figures per square millimeter, that 2 years later presented with occipital lymph nodes, not only replacing the lymph node, but also with extranodal extension, and the patient was dead a year later. So you can have all the spectrum from benign to malignant. The marker that is most important is GNAQ or GNA11, and this can be seen in blue nevi, melanomas, uveal melanomas, and a small number of lentigo malignas. Now, a lesion that is related morphologically but with a different genetic background is the pigmented epithelial melanocytoma. That, to distinguish from blue nevi, most of the cells are heavily pigmented, both macrophages and melanocytes. The old term that was coined by the group of Dr. Clark was the animal melanoma, but as you can imagine, that's considered to be pejorative because nobody would like to have a diagnosis of animal melanoma. And there are 3 pathways that I can bring to it. The most common one would be the BRAF lesion, but it can be also fusions associated with Spitz diagnosis and fusions associated with blue nevus. So it seems that the PEM is actually a final pathway of any of the 3. Deep penetrating nevus, very interesting, because it's a lesion that is characterized by a biphenotypic pattern of growth. Cells that remind us of a blue nevus, but they also have smaller cells that are standard nevus. Now, they have the cells that are pigmented are heavily HMB45, and they have also beta-catenin nuclear positivity. So the concept is that there is a standard nevus in which a second genetic hit that usually affects the beta-catenin pathway results in these lesions. And the WHO classification is proposing to have the concept of melanocytoma that I will say in a moment. And this can be the genetic alterations that can be seen in these lesions, whether they behave in a benign or in a malignant fashion. So the spectrum of melanocytic lesions, I think that supports the idea that there are nevi, there are melanomas, there are lesions that favor to be nevus, favor to be melanomas, and something in between, that it could be borderline lesion or melanocytomas. And to distinguish among them, we're going to need histology features, clinical features, immunohistochemistry, and the new techniques. So to finalize, because it's already 9 o'clock, the WHO classification includes pathways and molecular findings. Important that BAP1 deficient lesions are not a Spitz. They should be classified within the traditional pathway. Something that I didn't have time to emphasize, but now Spitzoid melanomas is a term that is given to lesions that have the morphology of a Spitz, meaning that they have large nuclei and prominent nucleoli, to be distinguished from Spitz melanomas, which have the typical findings of a Spitz lesion. So meaning, if you have BRAF V600D or other BRAF mutations, not fusion, or if you have NF1 or if you have NRAS, those are Spitzoid melanomas versus the others that they have HRAS or fusions that are Spitz melanomas because they have different survival. There are new entities that I will leave for another talk, and the need to further clarify the impact on clinical behavior of any of these fusions. So Kopkun Makrap as I tried before, and another image of the wonderful city of Bangkok. Thank you.